Welcome to the Low-Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor. Welcome to the Low Carb MD podcast. I am here today by myself. Dr. Brian could not be here today. And I am here with a special guest, Dr. John Schoonbee, who is a very interesting fellow. He's been putting on an amazing conference for a number of years now. And he's a physician. He graduated from the University of Cape Town. He was trained by the great Tim Noakes. And he was in family practice for 4 years before joining Swiss Re as their medical director. And I believe he's the global chief medical officer now of Swiss Re. He also helps put on 2 conferences yearly. One is the Food for Thought Conference, which is a collaboration with the British Medical Journal, and that'll be in October 10th and 11th. And another conference with just produced by him and Swiss Re, which is Fixing Metabolic Health, and that's on October 9th. So October 9th, 10th, and 11th, he's part of setting up education series to really spread the message of nutrition, that food is medicine, and that metabolic health matters. Both of these conferences are virtual and live. What I'm told is there's going to be some really smart people there. John, excited to have you on. Very happy to have you here.
Thank you, Troy. Lovely to be here.
Yeah. So, I always start with this, and if I got anything wrong, please correct me. But what I'd like to know, and I always, here we are, 2 doctors passionate about metabolic health, trying to spread the word about metabolic health in our own sort of networks and bubbles, and but I'm always interested in what the origin story was. What brought you to medicine? How did you get into medicine? What was it like when you were sitting there in physiology class learning from Professor Noakes? What is it that brought you to go practice for 4 years? And then, at some point, I'd love to hear about, why you made that transition to the sort of the corporate world.
Thanks, Troy. So maybe to correct a couple of things. I didn't join Swiss Re immediately. I joined a number of other companies in the insurance industry, eventually joined another reinsurer, Reinsurance Group of America, and worked with them for about 5 or 6 years till 2011, and then joined Swiss Re in 2011, so been there 12 years now. And then also the conference with the BMJ, this is the 3rd one. First was 2018, 2020, and so this is the 3rd one. And then Fixing Metabolic Health is quite new, and I'm sure we'll get to that later. But the backstory, so my father is a general practitioner, and he was a family doctor in a very small village where I grew up in South Africa. And he has 4 brothers. 2 of the brothers are also general practitioners. So 3 of the 5 were doctors, and then the 5 of them had quite a bunch of kids, and so I had 14 cousins, and I think probably about 9 or 10 of those cousins studied medicine as well. So there were a lot of doctors in the family, and it was kind of one of the things that was on the list for me to study. I really like mathematics as well. So it was always, do I do actuarial science? Do I do medicine? I eventually went the medical route, finished, my studies. Amazing hospital where I did my internship called Schoonbee in South Africa, in Cape Town, where they did the first heart transplant. And practiced for a while. And then I always had this hope of going back to maths and numbers and stats. And the reinsurance company it's just the perfect thing for me, because there's lots of numbers, lots of probabilities and survival statistics. But of course, you need to understand medicine. And now, being involved in this metabolic health movement and realizing what this could mean for the industry, and how much healthier we could make the population as a whole, and even our portfolios. Huge opportunity for us.
So here you are, you come from a family of doctors, and but you're interested in sort of numbers, and what was it like? You mentioned you practiced for 4 years as a family doctor, and what was that like? And at what point were you like, okay, I'm ready for something else? How did that happen?
I guess there are a lot of different factors. The one is, of course, as a general practitioner, when chronic disease is treated pharmacologically and not with lifestyle, you tend not to get anybody any healthier, right? And one of the people who tells this really beautifully is David Unwin, where he was a practitioner for so many years and he had just had enough, because just give people more pills, they get sicker, and there's very little kind of joy in that. I really enjoyed my internship in a hospital that was very fast paced. I loved my rotations in obstetrics and pediatrics, because this is like real medicine. You're saving people's lives, right? It's kind of medicine making a real difference. But depending on where you practice and how you practice, and the health system and what you're required to do and not to do, um, being a family doctor at a time before metabolic health was really a focus was frustrating and difficult. And then I also had this hankering after numbers. And so I thought, is there a way I can kind of combine those two things?
So you sort of saw what medicine was like. I mean, in your own family, you saw what it was like professionally, and then you said, you know what, I'm on to something else. I have a different calling, and so what I found interesting was, you were actually trained by the great Tim Noakes. So tell us what that was like back then.
I mean, it's amazing, right? He was, I mean, like one of the premier sports physicians in the world, and so renowned, and wrote The Law of Running, which was considered a Bible in terms of long distance running, and all about carbo loading. And it was so funny that he was teaching us physiology, right? Um, and and it's astonishing to think that somebody who was so renowned and so published would be prepared to challenge themselves, and go back and go, oh gosh, I got this wrong, and publicly state that. I mean, it's the most wonderful thing that a scientist can do that, because it's so rare. We know that, right?
Yeah, I mean, so we know. So you were trained by the best, literally in medicine, and you're in a family of medicine, and you go off because you have different interests. And at what point are you exposed, first exposed to this concept of metabolic health? So I'm imagining this is like the early 2000s, right? Or the mid 2000s. So that was right around the time, Atkins had died 5, 10 years earlier, and the keto craze is sort of just bubbling up, and so what was your first exposure to this concept of metabolic health?
So there was, as you say, it kind of bubbled up, and it was really interesting, because there were these people going, actually, fat's okay. Fat's not the problem. It's the carbohydrates and the refined carbohydrates. And it's so hard, right? Because, like all of us, if it's one lecture, 1 hour of nutritional science that you actually get taught, it's a lot. And you just get brainwashed by the media, by the guidelines. Um, and so slowly I started experimenting with this, and kind of realizing, gosh, I can eat a whole lot of this stuff and I don't put on a lot of weight. And but that goes against the paradigm, that goes against what I was taught. And then at the same time, Tim Noakes started kind of waving the flag, and started questioning what he had taught, what he had been told. And then more and more of this came out. And in fact, interestingly, one of my cousins, who is a GP, actually wrote the foreword of the Real Meal Revolution, which was one of Tim Noakes's kind of, you know, uh, fantastic publications around eating real food and changing your life around.
So it sounds like Tim Noakes, besides training you as a med student, it was his sort of public and sort of transition and admitting that he had gotten it wrong, that and that really inspired you to sort of re-examine this field. And so,
Absolutely.
as a numbers guy, how did you do that? I'd imagine that you would have gone straight to the medical, literature and said, show me the data, show me the numbers. So can you walk me through that process? I'm, there's no way you become the head of, the chief medical officer of a reinsurance company without analyzing the data. So help me understand that process. Like, you have your stat side, your critical thinking side, and now you're having to question, pretty much everything in modern nutrition. So what does that look like?
Yeah, so maybe some background. As a reinsurance doctor, really what you do is you accept the health of the population as it is, and you work out what the increased risk is of somebody who's ill, getting sick or dying. So it's not so much about kind of intervening in the health of the population. It's really kind of sitting back and determining, can we figure out what that health will be in the future? So in terms of the initial thinking, it was all about kind of more critical thinking. Of course, there was no long-term data, right? And then I had to educate myself in epidemiology and the weaknesses of epidemiology, and there are no RCTs. And all it was in the beginning, right, was biochemistry, really. So it was kind of trying to understand what's happening in the cell, and then anecdotes, anecdote after anecdote after anecdote. And I mean, how many people in the kind of community that believe metabolic health is the problem have said over and over again, right? N equals 1 times 1,000 actually means something, because we don't have RCTs, because we've got this historical epidemiology driving decisions. All we have are interventional trials, and it's very, very hard to kind of eventually get to a point where I feel confident enough to try and steer the insurance industry to think about focusing on nutrition, focusing on metabolic health, so that we can actually change the health of the people insured with us, right? And I think we're at a stage now where the best evidence and the totality of the evidence seems to be so strong that we can improve metabolic health, right? Unfortunately, by doing not what we're told by the dietary guidelines, but by doing what biochemically makes so much more sense, and eating foods that we've been eating for the last 2 million years, right? And yeah, changing the trajectory, really.
So it was really, anecdote after anecdote that sort of at least got you curious, but being a numbers guy, I'm sure you started to look into the data. So there must have been data that helped you sort of cement some of the things you saw clinically. I mean, as a clinician, we have to respond. We have to give credit to that clinical observation. I mean, we see it with our own hands. We feel it. We feel it in our own lives. We change our diets. I mean, I'm living proof of that sort of journey. But I mean, being a numbers guy, I'm guessing you looked at data. Was there any, do you remember like a study or something that like said, well, wait a second, this just adds to my, I remember 2007 was the A to Z trial, and then Shay's work, and a lot of stuff, between 2007 and 2010 and 15, there was a lot of data coming out. David Ludwig had, published a great study in 2001 on high GI versus low GI diets, amazing studies where he gave, people, low, medium, and high glycemic index breakfast, and they gave them another meal and then just measured how hungry they were. I mean, the simplest things, so how are you processing going against the grain at that time as a doctor, as now a doctor in the sort of reinsurance world and interested in metabolic health, and seeing your idol, Tim Noakes, the South African contingent, which is just awesome, by the way. Shout out to the Nutrition Network, everybody there, they're just an amazing group of people. So how is this, that's what I want to hear, the analytics, like what are the things that added to your, repertoire to change your own life, and probably what you're telling people around you to do, right? What were the things that sort of added to the anecdotes?
So as you've mentioned, right, there all these studies looking at it. I mean, it's almost like looking at a crystal, right? And looking at all the different facets of the crystal. You look at the David Ludwig work. You look at the at the kind of case studies that started coming out of diabetics, right, that lose weight. And I'm one of the first people that I understand why we need guidelines. I understand why we need standards. I understand why we need hoops to jump through before we tell people what to do from a medical point of view. We can't have people selling snake oil. We can't have doctors experimenting on their patients, right? So it's important that we have checks and balances. But unfortunately, it's completely swayed towards these guidelines, and doctors like David Unwin that are seeing these anecdotal patients going into remission. And what do you do, right? Because this is counterintuitive. This is not what the guidelines are saying. How do you gel those two things? And unfortunately, one of the things one has to do when you analyze all this is to start looking at the guidelines and start saying, okay, what are they based on? And that's one of the things Tim did, right? Is he went back and said, okay, so we've got the diet heart hypothesis. I mean, he came out of the starting block saying it's wrong, right? The data doesn't hold up. It's wrong. And I think that is one of the things that is necessary for people to move on, is that they need to go back. Everyone says, this is what we should eat. This is what's healthy. And then you go, well, why do you think that? Well, there's evidence. What's the evidence? Well, the FDA says so, or the CDC says so. That's not evidence, right? Why do they say so? What do they base it on? And yeah, but for me, another thing, is the biochemistry, right? I think the biochemistry is so important, to look at the pathways, to look at what is insulin doing. And that's another thing, that Tim Noakes was very good at when he taught me, but somehow he didn't put together the fact that you're eating a bunch of carbs and increasing your insulin. And so there was just never this this kind of penny dropping that we're messing this up by increasing people's insulin. So let's just reduce the insulin and see what happens. And you combine that with the diet heart hypothesis mess, and suddenly becomes quite clear.
Yeah, so it's like a mosaic evidence. You sort of grabbed some clinical stuff. The physiology didn't make sense. Some more data came out from the Unwins, and you're piecing it all together and leading you to be like, wait a second, this doesn't make sense. And you mentioned the CDC. I criticized the CDC about 8 months ago, 9 months ago in the United States because of their carb counting guidelines. Under their diabetes section, it said that 50% of a patient's diet with diabetes should be carbohydrate, and it went completely viral. We had thousands of retweets, and just so you know, exactly about a year ago, not a year ago, maybe 7 months ago, they updated the site and they took it off. No mention of data, no mention of change, no mention of why, right? It's disappeared.
But it's gone.
From their
That's
carb
amazing.
counting, which tells me two things, right? One, that they respond to social pressure, not evidence, right? And it tells me that that even our governing bodies, they get it, they can get it wrong, and they can change. So on one hand, it made me feel really terrible, right? Because nobody analyzed the data. They just took it down. They just took it down. They took that sentence down. Nobody said, we're changing what we did. We made a mistake, But on the other hand, it gave me hope that, hey, we can use organization, social pressure, education to change sort of some of the things that you and I both know are wrong. And you mentioned the diet hypothesis, and certainly, high glycemic index, diets are things that are still promoted by the AHA and the ADA.
Well, I mean, the guidelines all over the world are still WHO, 55% of caloric intake should be carbohydrate. I mean, there is just zero evidence for that. And so by saying that, you're forcing people to reduce their fat intake and have more carbohydrates and increase their insulin levels and trigger the whole problem.
I'm going to ask you some questions, and I wonder if I can get away with asking these. So, I'm just thinking, I'm here. I have a particular model in the United States. It's called direct primary care, which is, it means that, a patient comes to me and I don't take insurance. I don't deal with insurance companies, medical insurance companies, and they pay me directly, right? And my objective is to get them the healthiest they can be, to get them to live long and to not have a lot of medical issues, right? And that's exactly what they want, right? They want to live long. They want to, be disease-free to the best they can. If they need a medication, that's the only time where they want to use it, is if it's absolutely necessary. And so they want to be alive and healthy as long as possible. And now, since they're paying me directly, monthly, and regularly, I want them, I'm fiscally sort of aligned with their interests, right? I need them to be healthy, because healthy patients will, and I mean, not lack of better words, it's easier for me to manage healthy people than it is to manage sick people, right? So now our interests are aligned. Help me understand the insurance space, okay? When it comes to, insuring big groups, I'd imagine if you took a really sick group of people who could otherwise would be really expensive to get coverage, right? You gave them that expensive coverage and then you made them healthy, that would be a very profitable model. Has anything been looked at in the health insurance space like that? Is that a, where they're coming to you, they're like, I don't want to die. I want to live, I want to live a long, healthy life. And you're like, trust me, I want you to live a long, healthy life too, right? So you guys are in a position where your interests are aligned, and I'm in that position too. And we use nutrition as a vehicle to get people healthy. Has the reinsurance or insurance space looked into this at all?
Yeah, so I mean, this is the drum that I'm beating louder and louder where and when I can. And it, everyone has to own up to kind of conflicts of interests, right? And
That's good conflict. That's
No,
a great
exactly,
conflict.
exactly.
Yeah.
So I'm very happy when I present to say that, I'm an employee of Swiss Re, so it doesn't affect me directly, but the industry, if people live longer and are healthier, the industry is going to benefit financially, period. So there's no doubt that we will benefit more if we can get the population healthier. Like, and that's the alignment, right? And what a great alignment that is. So, and and I think it's one of the reasons why the insurance industry is so powerful, because we because we only want people to live longer, we can kind of be free of the shackles of big pharma or of governing bodies or of guidelines, right? Because no one's going to penalize us, because the only thing we want are people to live longer, healthier lives. And I don't want to say we'll do whatever it takes, but clearly, if we can steer and influence the world and the nutritional policies to be more evidence-based and allow people to be metabolically healthier, great for them and great for us. And I kind of want to raise this in case we don't get to it. One of the things, and I kind of want to go back to what you mentioned, somebody's very sick, they're paying high premiums, we get them healthier, it's profitable. Generally, what would happen is if somebody has life insurance and they're paying a lot more because they're sick, if they get a lot healthier, they could lapse their policy and take out a policy with better premiums, which is the right thing and fair, right? It's not really fair to charge people a bunch more when they don't need to be paying a bunch more. But the majority of people in our portfolios are paying what's called standard rates. So they're paying what we've priced as the average person. And if they get healthier, that average premium doesn't reduce, right? What does happen, though, is that the insurance companies, their profit margins will increase a little bit, their predictions of mortality will change, and people taking out new policies will end up paying less. So the policyholders will benefit, right, as well as the insurance companies. But fairness to me is one of the big drivers. And one of the things that drives me nuts is when I see people who are significantly overweight, right? And you see what they are shopping for. You see what's in their shopping trolley and in their baskets in the supermarket. And it is low fat and fat-free everything. And I want to scream because it's so unfair. They are trying. They are doing what they believe is the right thing for their health and their weight, but they're doing the wrong thing. And that's because that's what their doctors are telling them. That's what the nutrition people are telling them. That's what the guidelines are telling them. The government's telling them. And it's unfair, right? And the one or two lucky people out of, I don't know, 100 that go to you, that go to David Unwin, that go to Eric Westman, wow, their lives change, right? They get transformed like yours was transformed. And it's not fair that it's kind of whether you're lucky or not, right? To go to one of the challenging metabolically focused doctors. It's just not fair. And I want to get it to a point where everybody has access to a Dr. Tro.
Can I tell you it's so I share your mission. Um, you know, out in South Africa, there's the Nutrition Network. In the UK, there is the the collaboration,
Public health collaboration.
public
Yeah.
health collaboration, and in the United States, we didn't have one. We didn't have a organization. We started the Society of Metabolic Health Practitioners about 5 years ago. Literally, it was me and Doug, and I pulled Doug aside and I pulled Pam aside and said, we're starting a medical organization. And they're like, what? And I'm like, no, we're starting a medical organization. And, we've grown to about 500 members now. And it's been really on the backs of Pam and Doug, who've been such, citizen sort of evangelists. And now we have Eric Westman on the board with Rob Sybis and Dr. Laura Buchanan. And the goal here is to do exactly what you're saying, create an army of metabolic health doctors. I think that, and we partnered with the Nutrition Network, right, as the educational foundation for that certification, right? And we have, by the time this is released, it'll be announced. We have an official journal. It's called the Journal of Metabolic Health. We partnered with a South African publishing company, and we inherited the Journal of Insulin Resistance and are now rebranding it to the Journal of Metabolic Health. So now we have an official journal with a steering committee, with the publisher.
Wow.
Yeah, but we're all on that mission, which is nobody should be without metabolic care. And I'm just inspired by the fact that, you're in a corporate environment. You've sort of had to, a corporate environment I know can be very challenging. And here you are in your own life pioneering. I mean, would the, Fixing Metabolic Health conference happen without you? Would the Food for Thought conference happen without you? Can you talk a little bit about how you've evangelized your community and how these things came to be?
Yeah, I've been going to these conferences and talking to the kind of pioneers, I guess, of and reading about the pioneers of metabolic health, and initially, of course, it started as diabetes reversal, right? That was just the most obvious, astonishing thing, this progressive chronic disease that you can never cure, and suddenly. And so it began all about diabetes and reversing diabetes, and we know diabetes has costs, and so diabetes reversal, looking at carbohydrates, but even in the beginning, just saying low carb was problematic because a lot of people would get there, would kind of think that that's being a bit fringe. I mean, astonishing, right? 8 years ago, low carb, people would go, oh, hang on, you can't say that. Where's the evidence, right? Where's the Lancet study? But things have moved on so much, and being involved in this community, and seeing how people like Laura Saslow have helped change things, right? What does the American Diabetes Association now have on its website? Low carb is an option for diabetics. It's amazing. What's the NHS doing? In the UK, they're training doctors on low carb um, kind of strategies for their patients. So there is so much good stuff happening. But one of the things, and low carb was tricky, right? And then, of course, after low carb came the idea, wow, we can be in a ketogenic state, right? And Veda Health gets all its diabetics to be in a ketogenic state, and we're measuring ketones. And then you talk about ketogenic, and all the doctors get confused between ketogenic and acidosis. And it is just a complete mess. And they think, well, you're super French if you're talking keto. And it's just slowly over time, right? One has to navigate the natural responses that people have because of the media, because of pressure, because of society, I guess. And slowly it's come to a point now where we can say keto and not be, considered to be completely fringe. And certainly if you say keto for young children who suffer from epilepsy, and they can't get relief from the medications, then a ketogenic diet and it's been around for 100 years, right? And we have these new case studies of, and again, biochemistry kind of proving why severe psychiatric conditions on a ketogenic diet. And so again, it's becoming this multifaceted thing again, where you're going, gosh, look at all this stuff. And it's not just diabetes, and it's not just obesity. Of course, diabetes and obesity are headlines, and that's one of the reasons why the collaboration with the BMJ is focusing on diabetes and obesity. But I wanted to create this kind of separate event called Fixing Metabolic Health, because metabolic health encompasses all of it, right? It encompasses insulin resistance. It encompasses all the non-communicable diseases that we see today. And when you talk about metabolic health, and I love the name of your new journal, everyone buys into metabolic health. Like, who doesn't want to be metabolically healthy, right? That's fantastic. Um, and it's almost the same as these companies that are using continuous glucose monitors, right? And I know you're a big believer in CGMs. And there are two reasons for me why CGMs are so fantastic. One is it's feedback. It's direct feedback all the time, right? Which really helps with behavior change. The second thing is that you can, to some degree, be a little bit agnostic in terms of telling people what to eat or not to eat, right? Of course, we want people to eat real food, whole food, etc. But if you just say, don't spike your glucose, right? Reduce your glucose spikes, they will naturally end up. And of course, I suppose the third thing is that it's individual. Then everyone believes, I'm individual, I can eat carrots, you can't eat carrots, but I can, and that's great. I think there's a 80-20, 90-10 rule that, the, the basic premise of avoiding ultra refined carbohydrates or refined carbohydrates and sugar is enough, right? You don't really have to personalize it, but it's good to be able to say, let's personalize your carbohydrate intake because, again, it allows people to feel they're not being told what they can and cannot eat. It's just about what spikes me, and I'm different. So CGMs, I think, are fantastic. And you take CGMs, you take metabolic health, and kind of suddenly everyone's on board and everyone's okay to think about this, to talk about this. Um, and I think it's a great platform. It's a great platform.
Yeah, we had a large employer. We have a couple large employers that we work with, and one of the wellness programs we did. I'm sure you know, there's wellness programs in these employer, in these big employers, and maybe they want you to just be aware of your lipid numbers or your blood pressure or your blood glucose, and we worked out a different pathway in this employer where we said, look, rather than spending that money on a blood lipid level, why don't we give them a CGM and let them see sort of what happens, right? There's not a lot of data that these know your number campaigns have great impacts. I mean, there's some impact certainly on it's great to help risk stratify a big pool of people. It's helpful to but it was an absolute success. And people hate these type of campaigns. They feel coerced. Well, they said, well, now you have an option. You can do this or that. And so many people chose the CGMs, and they got to start being involved in how everyday decisions impact their body, rather than just sort of getting a number and saying, well, your cholesterol is high. Well, what exactly does that mean? Your triglycerides are high. What exactly does that mean? You know that number now. Well, you go to a doctor, they don't even know what to do for high triglycerides. So, so this was an alternate pathway we made, and the patient engagement, the patient sort of happiness with it was really through the roof. They came to meetings that we offered in our app, like just to sort of understand these blood sugar fluctuations. In fact, just before this podcast, we had a meeting. There was like 40, 50 people in, just learning about blood sugar fluctuations and what they mean. And so, I think that there's the people who have aligned interests, like the employers we work with, who actually care about the health and the happiness of their employees. They are coming on the metabolic health bandwagon much sooner. People like me who rely on performance, meaning like how well our patients, how healthy our patients are doing. We are on this bandwagon, and it sounds like the reinsurance world or the insurance world is at least thinking about how is it, those interests are aligned. And you're absolutely right that CGM is just a tool that cannot be, it's such an amazing biofeedback tool. And ultimately, it's also, a lot of people who struggle with weight are eating subconsciously. They don't even know what they're eating. They don't know how much. They're just not attuned to it. I mean, just like we don't count the amount of breaths we take, and we don't count the milliliters of urine we make and the amount of milliliters of water we take in. We don't do this, right? Many people aren't cognizant of food, and I'm even guilty. Here I am, a double board certified fancy physician, right? I can't tell me how many times I pass the kitchen and I grab, a handful of nuts or something like that, and I just it doesn't even register. So that CGM could be really empowering to sort of wake the person up without any shame, without any, it's like, hey, get an idea of what you're actually doing to your own body, and not in a big beyond food, sleep and its effects on your body, and stress,
Exercise. Yeah.
bingo. So it's a common language. It becomes a common language that blood sugar, it's not everything. There's more to medicine than a blood sugar graph. There's more to lifestyle than a blood sugar graph. But I'm with you. It's a revolutionary tool, and we're the biggest prescriber on the East Coast of CGMs, and
Wow.
I'm so passionate about it. We literally nationwide, we will. We prescribe CGMs basically anywhere in the country right now. You can go to our app and get a CGM for essentially what it costs us. We would like to make it even cheaper, but the pharmacies get benefits that they don't give to doctors, group benefits. So Dexcom and Abbott, if you are listening, we are very happy to get some of those rebates that you give to pharmacy benefit managers to make these tools more accessible.
Joe, can I mention, just you kind of alluded to it, right? The wellness programs at employers.
Yeah.
So a bunch of insurance companies also have wellness programs, and there are a variety of reasons why they have wellness programs. One is they hope to improve the health of their policyholders. The other is it's a kind of it becomes a hygiene factor because their competitors have one. They have to have one as well, right? So they kind of have to jump on the bandwagon. And a lot of these wellness programs are very similar, right? It's try and exercise, measure your steps, gym memberships. A bunch of them get you to do annual checkups, screening, for example, which in and of itself is valuable for some people, right? But when you look at the nutritional guidance of these wellness programs, it's, how many times a day do you eat salad? Do you eat chicken with or without the skin? Do you eat less red meat less than once a week? Do you add salt to your food? Like, these are seriously the questions that they're still asking, right? And yeah, so there's just so much repetition of the wrong dietary advice. It's astonishing. I wrote an article on LinkedIn yesterday, in fact, and one of the things that I've been wanting to write about was salt. So it's just such a lovely kind of example of the mess that nutrition is in. So in the US, right, CDC, whoever it is, I think, says less than 2.3 grams of salt a day. Europe, less than 6 grams a day. So here we have two supposedly really academic, fantastic, powerhouses, and their health experts have a 2.5-fold difference in the maximum amount of salt that you are meant to take in. And none of it's based on RCTs, none of it. It's astonishing. It just highlights, and people just don't realize how little evidence there is. And you can throw all that away and kind of start with, hang on, what's affecting your insulin levels? What is natural? What is unprocessed? What did we eat, a few hundred years ago, mostly? That's almost all you need to do.
It's we had Andrew Mente on the podcast, and it may come out after you. So if you're a listener, and we go through that salt literature, and if you Yeah, well, a lot of things are coming to my mind. Wow, you touched on so many important points. One of which is wellness programs need to monitor the effect, which is what we are doing. And which is what David Unwin has done and Verta is doing, right? We are monitoring the effect. So how effective are we, right? And we the most shared article from BMJ Nutrition is Dr. David Unwin's article on a analysis of his practice, showing the sustained remission of diabetes in countless patients. When we're working with these employers, we are building in some of the costs. The reason why we're a fairly costly wellness program is because we have built in the fact that we need to track our effect. We need to get better. We need to know what effect we're having. We need to know how we improve, what we do improve, what we don't improve. And what we found is exactly what you'd expect, which is, the cost savings is just a piece of the puzzle. The worker happiness is a whole nother side. The productivity is a whole nother side. All these things that you can't quantify. When somebody, in one of our employer programs, such as in Louisiana, we have 5 patients who've lost 100 pounds or more, right? You can't even quantify how their lives have changed, right? How their families' lives have changed.
Exactly. The quality of life, right? The quality of life. And that comes back to the fairness.
Yeah. So the bottom line is, the most important thing is sort of, and I think for these wellness plans is to, figure out to track exactly the effects that they're having, because that is what's going to make us better. It's going to make us feel better. And you just mentioned so many, that fairness piece, which I have to highlight also. You've talked about like that aligning interests and fairness. The companies that we've loved to work with, right, have been those companies that have said, because I've met CEOs of companies who are like, look, I just want to save costs and we want to check the box. Like, just like you said, other insurers are like checking that box, right? And those aren't the fits that we want. In fact, one of our biggest employer programs, when I talked to the CEO and I said, here's how much we're saving you, right? I thought like, he's going to give me an attaboy, right? Like, here's how much we've saved you in, whatever claims and prescription drug costs. He's like, Tro, you have it all wrong. And this warmed my heart so much. I cannot believe it. He said, I don't care about that. I'm like, well, what do you mean? You're a CEO, you have 10,000 employees, like, what do you mean you don't care about that? Like, you're the 1% of the 1%. And it's like, I don't care about that. I'm like, it's like, I care about how happy my employees are, how productive my employees are, how healthy they are. Are they happy to come back to work? Right? Are they happy? Are they like inspired? Do they know that we are behind them 110%? And, it's like, it struck me like, we're doing we're preparing these papers showing how good we are with diabetes, how good we are with prescription drug savings. And he just ripped it up. He ripped it
Punishing.
He ripped it up and he was like, I could care less.
So
there are those great people out there.
they are. So I want to just highlight your study. I have used your study of the 10 very overweight people, right, at an employer who you put on your program, and they lost they dropped their heart event risk by 44%, right? Their 10-year heart effect, the heart event risk, and so I've used that a number of times, and what I try and do. So you've asked previously about numbers, is I try and take those and I try and convert them to what it would mean financially for an insurance company. And it's kind of, you take these people, you take their pre-program average cardiovascular risks, and we've got a calculator that works out your mortality risk because of that. And then you take their risk at 6 months with your first study, and you compare the two, right? And on average, that risk has dropped dramatically. But currently what it is, it's a proxy of the cardiovascular risk factors, right? It's a proxy. And it's obviously really sick people. If you take your study, if you take David Unwin's study, it's less sick people. But it's kind of taking studies like that, putting them all together and saying, if we had a portfolio and 7% of adults in the portfolio were type 2 diabetic, what would it mean if they were pre-diabetic and we improved them? What would it mean? So we try and model all of that, right? And the impact on a portfolio is enormous. It is enormous. And one of the things when we look at, and particularly what you're doing with your employer groups, is it's medication costs, right? That's the joy of diabetics, is you take them off insulin and you save a ton of money. But for me, it's medication costs. So we don't do a lot of health reinsurance. We do mostly life reinsurance, but it's the medication costs. Then it's going to be utilization costs. Then it's going to be hospitalizations, strokes, heart attacks. And we have products, right, called critical illness products. We sell a lot of them in Canada, in the UK, in South Africa, Australia, and Europe. They pay out on the diagnosis of a cancer, of a heart attack, of a stroke. So can you imagine the reduction in those portfolios, right, when we start getting people metabolically healthy? And then you're going to get the mortality reduction at the end. And the other thing, which is linked a little bit to what you said about this great CEO, is people's mental health improvements are so enormous. And I think that's one of the most underestimated benefits, is the mental health improvement, right? And occupational disability products are sold around the world, right? You can't work anymore. Most of the claims for disability are psychiatric and musculoskeletal, right? And when you look at the underlying cause in insurance or in terms of claims, we're just like we are in medicine. We are binary and we are single cause driven, right? Why is this person in hospital? Tick a box. Why did this person die? Tick a box, right? And when people are disabled and life is too much and they're BMI of 45 and they're injecting themselves and they have anxiety and they can't sleep properly and they have aches and pains and they have inflammatory and they have brain fog, it's not a single cause. Well, it is. It's metabolic ill health, right? And if we can really shift the metabolic health of the population, the impact we'll have on mental well-being is going to be enormous. And that's really exciting because that's something that, like, I hadn't even thought of it before, right?
Yeah, it seems like it's in our reach, but I I truly think the future is going to be exactly what it is you're doing, what the Nutrition Network's doing, what the SMHP is doing, what the Public Health Collaboration is doing. I think we need to organize this message, and create defined organizations that that really champion the message of metabolic health and focus on removing the dogma out of some of the nutrition messaging. And it's going to start with it's been there. I mean, and Tim Noakes has been fighting this battle for over a decade. Same with Dave Unwind, and for the last several years, you've put on these conferences, Food for Thought, and now Fixing Metabolic Health. Hopefully, we will include all the links to those in the show notes. So if you're listening to this, it'll be there. They're free to register, to watch virtually. Any parting words of wisdom, any parting words before anything else? Where can people find you? How do they interact with you? What's the best way somebody should, if they listen to this, is it through the conference website, or how should they get you?
They can get me through the conference website. They can get me on LinkedIn, right? They can get me on Twitter. So would love to interact with people, because part of this is education, and that's what I'm trying to do, is to educate my colleagues at Swiss Re, my colleagues broader in the industry, and the more we can educate people, the more people can question the dogma that they're being told.
Absolutely, 100%. So I follow you on LinkedIn, so people can follow you on LinkedIn. On Twitter, I got to follow you now. We'll get the handle. We'll put it in the show notes. And guys, it's the Food for Thought conference with the British Medical Journal, October 10th and 11th, and the Fixing Metabolic Health conference on October 9th. Thank you again.
Tro, thank you, and keep being strong. Keep doing what you're doing, helping the world.